Greetings, Earthlings, and good morning. So, we're going to be talking about abdominal wall anatomy, and specifically as it relates to the creation of incisions that are used in gynecologic and obstetric surgery. We have some videos that we're going to selectively watch, including some animations and videos of live surgery. So, let's jump right on into it. So, a little bit of an overview of the anatomy that we're looking at. We are usually going to be fairly inferior down here at kind of the level of pubic symphysis, and you can see pyramidalis muscle here, kind of that triangular shape, and of course there would be another one over on the other side there. When we do a fan and steel incision, we're about 2 finger breadths above pubic symphysis here. When we do a malar, a bit higher, and then obviously a midline vertical starting about 2 finger breadths or so above pubic symphysis and incising upward. If we go supra umbilical, starting here, coming down, curving the skin around umbilicus and then down, sweeping umbilicus over, and then incising the fascia here, the linea alba, in a straight fashion. One of the things that we're going to look at in a second, just when it comes to layers of the abdominal wall, is the arcuate line here. And if you remember way back to anatomy class, below the arcuate line is where the fused fascia tendons of the oblique rectus muscles and the transverse muscle, where those fuse into one and go over the top of the rectus abdominis. Whereas above the arcuate line, there's a bit of a division of some of that going behind rectus and some of it going over the top. So again, we've got some illustrations to look at that. So above the arcuate line, we're not going to spend much time here, but again, we've got external oblique, internal oblique, and transversus. And again, it's this one in the middle, the internal oblique, that it's split and that divides over the anterior posterior aspect of the rectus muscle here. But we're really going to be down here below the arcuate line for most all of our work. And when we're above the arcuate line, it's mainly for vertical incisions, so we would just be right here, kind of coming through linea alba itself. All right, so below the arcuate line, what we have here obviously is the skin, subcutaneous tissue. We have the 3 sheaths of the outer muscles here coming together and forming the rectus abdominis fascia here, just anterior to the 2 rectus muscles, this linea alba in between them. A bit of preperitoneal space here, and then preperitoneal fat and peritoneum right there. So to break this down a little bit more, the layers that we go through, and we talk about the layers that we go through with the C-section because that's the surgery that we obviously do the most. We tend to use fan and steel incisions for those, and so that's kind of the default of what we normally talk about. The layers that we go through, obviously we start off with skin, then subcutaneous tissue divided kind of into 2 layers, this more kind of fatty areolar connective tissue of Camper's, and then a little bit more fibrous, usually a little bit of a whitish lip to it of Scarpa's, and then the rectus fascia here, rectus muscle, and then down kind of into this peritoneal connective tissue and the peritoneum itself here. Couple of things to keep in mind as we're going through this with the skin, and then below into the Camper's and Scarpa's. I remember that as Camper's, Camps on Scarpa's. Okay, and we already talked about the layer that's the kind of what we talk about in general as the sub-Q layer here, is obviously of variable depth. Based on a patient's body habitus and adipose distribution. We're going to talk about closing that layer specifically Scarpa's is a more membranous layer that's usually fairly defined and is visible, but not nearly, of course, as significant as the rectus fascia here that we really pay a lot of attention to as far as how we open it and then how we close it as well. So as far as different types of incisions, obviously we've got a lot to pick from, but when it comes to obstetric gynecologic surgery, we're fairly consistent with what we do. We look at number 9 down here, the fan and steel. Yep, that's kind of our number one go-to. A Maillard incision that we'll talk about is usually just a bit above that and a bit straighter. And then midline vertical, again, which you can do just below umbilicus, or you can bring it up. I usually come around that side on the skin to go up above umbilicus as well. All of these other kind of paramedian and the gridiron muscle splitting for appendectomy, we don't do those really at all. When it comes to the selection of what type of incision we're going to use, we've got various factors that play into it. One of them is rapidity of entry. How quickly do you need to get in? For the most part, people think of midline vertical incisions as being the fastest way to enter the abdomen. However, it's something that we don't do nearly as frequently, especially for C-sections. And so some would argue that going with what you have the muscle memory of and what you do most frequently, which would be a fan and steel, and there are ways to kind of abbreviate that and use a bit of blunt dissection in certain steps. So some people would say that they actually believe they're faster at getting in with the fan and steel. But one of the things that we think of is how quickly do we need to get in. Another thing is how do we need to access the tissue? Are we certain of what our diagnosis is? Or do we have some uncertainty about potential malignancy, and so the need for quite a bit of a wider view or potential lymph node dissection? Patient's body habits clearly plays into it, and specifically when it comes to C-section, there are decisions that we make about skin entry that are based specifically on habitus. Previous surgeries, previous incisions, so obviously scar tissue, adhesion formation can play a role in how we decide to approach the abdominal wall. We obviously do incisions to try to minimize bleeding, to minimize pain. That's partly with the closure of the incisions as well. And then obviously cosmesis, is absolutely a consideration. We need to pick the right incision for tissue access and getting the procedure done in the safest way possible. But the only thing out of all the work effort we put into the surgery, the only thing the patient's really going to see is the skin incision. So getting that to have kind of a minimal cosmetic impact, have it heal nicely is very important. Anyway, when it comes to making incisions, there are sharpened cutting instruments that date back to the Egyptian dynasty, so about 3000 BC. Let's see. So types of incisions, we already talked about some differences here between transverse and vertical. Vertical has that more rapid entry in general. It's very expandable, so you can get great abdominal exposure. Obviously, the length, as we said, is quite variable, and that whatever length you start with, you can extend it during the case quite easily. Because you're going in the midline, nerves, vessels don't tend to cross the midline. I always think of that just in terms of like the dermatomes as well. Remember, shingles always on one side, doesn't cross the midline. So by staying in the midline, you can minimize vascular and nerve injury. However, you do have an increased risk of dehiscence and hernia with vertical incisions, and so the closure there, the fascial closure especially, is very, very important. Transverse incisions do tend to have a better cosmetic result because they're obviously confined to a more inferior space and is covered up by clothing a bit more easily. You do have kind of more dissection, so to speak, to get through the layers. There is an increased risk of nerve and vascular injury because of the kind of the nature of the location and direction of the incision and the underlying tissue dissection. There can be limited opportunities for extending a transverse incision if you find that you don't have the access you need, especially if you do a transverse incision and really need more lateral access. You can be a bit limited, and then especially if you need superior access. If you really have a big uterus, you need to get a bit higher up into the abdomen, the transverse incisions can be quite limiting there. So there are some options that you can do to help with that, which we'll talk about. The superior exposure we just discussed. They do have increased intrinsic strength, so there is less risk of dehiscence and hernia formation. So vertical incision in general, and you'll see a lot of different approaches to this. I don't think there is a single right way to do it, but in general, we want to minimize tissue trauma, we want to maximize exposure, we want to be able to do the surgery safely, and then again have a cosmetic consideration. But in general, we start about 2 finger breadths above the pubic symphysis for our skin incision, and then depending how you're going to start, but coming below umbilicus and straight down to the midline. If you know that you're going to need to go above umbilicus, I will usually cut down here, and then having marked this out with a marking pen, come around the side and then down. The length of the incision, again, like we said, it depends on diagnosis, organ anatomy, the patient's body habitus. As you go down through skin and subcutaneous tissue, you're going to get down to the fascia. So again, you're going to be identifying the linea alba. And in general, there's going to be one side of rectus muscle that tends to fall away a little bit. So whichever side is falling away a bit more naturally, you're going to kind of bluntly dissect muscle off to the side there. That's going to give you an opening here where you've identified peritoneum, and then opening peritoneum, you're in. We already talked about this, curving the skin around the umbilicus, but then sweeping the umbilicus laterally here so that the incision that you actually make in the fascia is straight up and down. We don't want to have a curved incision in the fascia itself, straight up and down, which is best for reapproximation of fascia and then healing and minimizing hernia formation. So layers here, which we've already talked about a bit, going through skin edge here. We've got our subcutaneous tissue, again, this loose areolar campers, and then scarpas down here. This edge here, the white area, is the fascia itself. That's been opened as well. So here's our linea alba and rectus muscles there. Occasionally, the rectus muscles will really truly be meeting in the midline, and so you just have to find right in the middle, spread them apart a little bit, perhaps with a hemostat, get your finger in there, identify the linea alba, and then as they're depicting here, you can tent that up, open it with scissors or scalpel, and then extend that opening. Once we've got the fascia opened here, then you can see peritoneum here, which you can enter again sharply or bluntly. So, transverse incisions. Again, fan and steel, absolutely the thing that we use most frequently here. So it's kind of a somewhat curved, about 2 finger breadths, 2 to 3 centimeters above the pubic symphysis. And then as far as length, it depends what procedure you're doing. Like we talked about with a malar incision, it tends to be a little higher up and more of a straight incision. We don't really tend to go very low with the fan and steel, and you can see here we've gone from rectus muscle down to the rectus tendon here to where it's inserting on the symphysis. We're going to talk about that when it comes to the Czerny type of incision, which is kind of an additional step of dissection that you take after having done a fan and steel. So let's talk about fan and steel. It's a muscle splitting, not a muscle cutting incision. That's important. It does have somewhat limited superior and lateral exposure. So if you're working right on the uterus, great visualization. If you need to get way out to the side, or again, big uterus, you need to get higher up, it can be very limiting there. Again, start about 2 finger breadths. I would say kind of 2 to 3 centimeters above the symphysis, not as much as 4 to 5. Around 12 centimeters long is kind of a typical length for fan and steel. And then one of the things that we do is we do separate the fascia off the rectus muscle. So here you can see that they've opened skin, the subcutaneous layer here. Here's our rectus muscle. They've spread that open in the midline, and here's peritoneum. And then once we open peritoneum, then again, if we're talking about C-section, uterus would be right there. As far as who this was named after, we don't really get much into tombstone medicine and talking about all the old surgeons who had things named after them. But Hermann Johannes Pfannenstiel, who actually published articles about this type of incision in 1900 and a bit before, himself died in 1909 of sepsis after he cut his finger during a surgery for a tubo-ovarian abscess, and then he got septic and died. All right, so fan and steel, again, we've gone through skin and subcutaneous here, so we're down to the fascia itself. The fascia here is, after it's incised, it's reflected up and separated from the underlying rectus muscle. So we've got this nice big opening in fascia, and then bluntly and sharply dissected it off of rectus. The rectus is then split in the midline, just kind of pulled laterally, exposing peritoneum, and then the peritoneum is opened. You can see here with the external oblique muscle coming in, over here maybe on the left a bit more, that's kind of the line of demarcation for the opening of the fascia. We don't want to go into the muscle itself. All right, so let's look at a couple of videos, and we're going to look really just at some highlights of things here. The first is an animation doing a fan and steel for C-section.
The patient is placed in a supine position with a drape screen set up. Working spinal or epidural anesthesia is administered. The procedure starts with a fan and steel incision, dividing the skin as well as the subcutaneous fat. The rectus fascia is exposed and is also divided. The rectus abdominis muscles can then be separated bluntly, revealing the peritoneum layer underneath. The peritoneal cavity is carefully entered, and the incision is extended along with the muscles. The lower uterine segment is exposed.
All right, so that's it. Those are the steps as we just talked about, and a nice overview. This next video we have is actually in a pediatric patient, but it's a video that I came across that actually has a very nice dissection because of the kind of health and simplicity of the anatomy.
And peritoneal reflection. The superior aspect of the symphysis pubis is first identified by palpation. The incision is made approximately 1 to 2 finger breadths superiorly in a semicircular configuration along a natural skin crease. In a pediatric patient, the incision is typically 3 to 5 centimeters in length. The first layer deep to the skin and superficial to Camper's fascia is the dermis. Deep to the dermis, Camper's fascia is then seen as the superficial fatty layer of the anterior abdominal wall. Note that several small vessels run through this layer, requiring meticulous use of cautery. Next, pickups are used to grasp and elevate Scarpa's fascia for division. Here, Scarpa's fascia is incised on the right side first. Deep to Scarpa as the rectus fascia can be visualized. Scarpa's is incised on the left side. Note how well defined this layer appears here.
We very commonly do not see Scarpas outlined quite so beautifully as this, but oftentimes if you look for it, you can identify it specifically. As far as how this is opened, you can open the subcutaneous tissue bluntly, you can do it sharply with scissors, you can do it with electrocautery as they're using here.
With a bird's eye view, the rectus fascia is clearly visualized, as well as the 2 cut layers of Scarpa's and Camper's fascia. A small opening is made into the right side of the rectus fascia, and
so when we enter the rectus fascia, we usually use the scalpel to cut across in the midline, creating a little opening on each side.
Fascia is then divided. Note here that as the incision is carried laterally, 2 layers of the rectus fascia can be seen. The deeper layer represents the fusion of the aponeurosis of transversus abdominis muscle and the internal oblique muscle as they fuse with the aponeurosis of the external oblique muscle at the lateral border of the rectus. The convergence of these layers forms the anterior rectus sheath, otherwise known as the rectus fascia.
And again, when it comes to opening the fascia itself, you can use a blunt technique to do that. Scissors and pickup with teeth are what we most commonly use, or you can undermine, open up, spread a hemostat or Kelly here, and then use electrocautery.
Here you see the divided fascia with the underlying rectus muscle. The remainder of the rectus fascia is then incised, revealing the pyramidalis muscle inferiorly.
So the area they were picking up there is the linea alba, picking that up between the two forceps and then opening right in the middle.
The remainder of the rectus fascia is then incised, revealing the pyramidalis muscle inferiorly. The fascia is first elevated off of the rectus inferiorly to gain exposure.
We do this
Here, the
sharply
pyramidalis
and
muscle
bluntly.
comes into view. This is a small triangle-shaped muscle anterior to the rectus muscle that attaches to the pubic bone and linea alba. This muscle tenses the linea alba. Typically, its attachment posteriorly to the rectus muscle is left intact. Similarly, fascia is elevated off of the rectus superiorly. Retractors are then placed for better
So again, you can see here in the midline, you've got some separation of rectus up top. When you get down to pyramidalis, it's usually a bit more sealed, for lack of a better word.
visualization of the linea alba. The linea alba is the tendinous midline between the two rectus bellies. In most children, there's very little prevesical or perivesical fat. Once the rectus bellies are separated, the distended bladder can be immediately visualized.
So they're really having already
In this
gotten
child
down
who is
to the
undergoing an
bladder, so they've
intravesical
performed a
ureteral
cystotomy
reimplantation,
here,
a vertical anterior cystotomy is made.
which we will not be doing. All right. So let's move on and talk about a Czerny incision, which unfortunately I was not able to find a video of. One of the things with the Czerny is that it is like a fan and steel. It's a muscle splitting, not a muscle cutting incision, but it does cut through the tendinous portion of the rectus and pyramidalis where they insert on the pubic symphysis. So basically, if you have performed a fan and steel, so you've divided the fascia, you've separated the fascia off the rectus, you then take this next step with the Czerny, which we'll look at in a second. By doing the Czerny, it basically releases the rectus abdominis muscles and pyramidalis from the pubic symphysis, so that you have quite a bit greater laxity of tissue and a larger space to be able to do kind of blunt dissection stretching to increase your exposure. So it specifically gives better inferior, but also some superior, maybe lateral exposure by loosening the rectus muscle. The thing is that at the end, you have to reattach the tendinous portion to the symphysis, because if you don't, the rectus muscle is just going to be flapping in the breeze. So the way that goes, and again, we've got skin, subcutaneous tissue, and then fascial edges here have been divided. The fascia is being reflected inferiorly, and the fascia has already been dissected off of the rectus muscle. So what the Czerny is doing, it's not cutting the muscle itself, but it's coming down to this tendon here and cutting through the tendon. Pubic symphysis is going to be right about here. So you don't want to cut directly on the symphysis, because you need at least a little bit of a tendinous pedicle here, so to speak, to be able to reattach to, because again, you have to reapproximate the muscle and tendon to a little bit of remaining tendon on the symphysis. The demonstration that it has here is doing a bit of a kind of a multi-layered closure to really bring those two together. All right, malar incision. So malar is quite a bit different in that it is superior to the fan and steel, 6 to 8 centimeters above the symphysis. It's a straighter incision, so not really curving up the sides. You can also go a fair bit wider with it. The big difference, this is a muscle cutting surgery, and you do not separate the fascia off the rectus. So you, over here on the left here, again, they've gone through skin, subcutaneous layer here. They've incised fascia, but left it attached to the muscle. And then here they're using electrocautery to open the muscle itself. And then here would be peritoneum here. So if we look over here at the actual dissection, you can see that the rectus muscle, and here's cut edge of fascia here, that it's not been separated off. The muscle is still attached to the fascia pretty much all the way down to where the fascia was divided. And then here is the cut belly of rectus that had been divided from here, and then here's the cut rectus on the other side. So you can see that already this gives quite a larger area of exposure, and specifically lateral exposure once the peritoneum here has been opened. When it comes time to close this, I'm not a fan of suturing muscle in any circumstance unless you have a specific area bleeding. But when you close this, you don't close muscle, you close fascia. So by closing the fascial edges, it will bring the two cut surfaces of muscle in close enough proximity that they will heal. One thing that you have to do with the Maillard is identify your inferior epigastric vessels. So if we come over here, we've got rectus muscle that's been removed, but it would be coming down kind of through this area. So here, and the inferior epigastric vessels are coursing right up here. So before we cut all the way across the rectus, you have to identify the vessels, which are being shown here, and ligate them. Couple of things with that. You will occasionally see some division, some cutting into rectus to give a little bit more lateral exposure, which is an okay thing to do as long as you limit it to, say, 2 to 3 centimeters. You want to divide less than half of the width of rectus. If you're going to start to divide more than that, then you need to think about tying off this vascular supply. Even with a fan and steel, where you've elevated and separated the rectus fascia off of the muscle, you can still divide the rectus somewhat as long as you leave the majority of it intact. That'll heal up. If you, as with a fan and steel, separate the fascia off the muscle and then cut the muscle completely, when you go to close the fascia, the two muscle edges will have, because of just the natural resting tone of the muscle, the two cut surfaces of rectus will have retracted, which they were free to do because they'd been separated off of the fascia above them. The two cut surfaces of rectus retract, and then they won't heal. So you'll have hernia formation there where you've got only fascia holding the abdominal wall together with that separation, and so now kind of non-functional rectus. So what some folks do before they cut any of the rectus, which again, here's kind of the body of the muscle, and then it comes over here. What some folks do is they'll come out laterally, identify the vessels and ligate them, then start cutting the muscle. Some folks will start to cut through the muscle, and when they get about halfway through, start to do a little bit of careful dissection to find the vessels. Some folks, before they really start their dissection, will just try to dive down through muscle and find. There are a variety of ways to do that. All right, so let's look at a video here that we have, and we've got two, one's kind of an animation and then another from live surgery.
A Maillard incision is planned, which increases exposure and access to the pelvic side walls compared to a fan and steel incision, while allowing for a transverse skin incision. Transverse incisions have lower postoperative pain, hernia formation, and adhesions compared to midline incisions. Since the fascia is open to the lateral borders of the rectus muscle to expose the inferior epigastric vessels, the risk of iliohypogastric and ilioinguinal nerve injury is increased. Therefore, a higher skin incision will avoid injury to these nerves, which are more lateral in this location. The patient is positioned in dorsal lithotomy. The abdomen is entered using a Maillard incision. The skin and fascia are opened horizontally. The fascia are opened horizontally. The skin and 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 fascia are The inferior epigastric arteries are then identified.
So I would suggest that here they make it appear as if they have maybe separated fascia off the rectus muscle, but that is not the case. This is just having incised the fascia and then spreading it. It's kind of over-exaggerating how much of a separation there would be in fascial edges there.
At the lateral border of the rectus sheath, skeletonized and ligated bilaterally. The rectus muscles are divided and the peritoneum is opened horizontally. The uterus is exteriorized from the abdominal cavity.
And I'm not sure if they talk about closure.
A tourniquet is placed at the cavity. The peritoneum is closed, followed by the fascia. The skin is closed.
So just closing fascia itself. All right, and then here's an example from a surgery.
Technique. An incision for complex abdominopelvic gynecological surgery. It is an extended transversal incision characterized by the bilateral ligation of the deep inferior epigastric vessels and the transection of the anterior rectum abdominal muscles.
So this does show, I think, a more realistic view of how much separation you're going to get with the fascia. So it's opened, but they're not dissecting it off of the underlying muscle. Actually, they are dissecting it off there.
A wide dissection of the fascia, it is not mandatory, but it is important to have enough surgical fill for the dissection of the epigastric vessels. This is an important step, and here we should pay attention to avoid damage on the epigastric vessels. The Hesselbach's triangle or inguinal triangle is the anatomical region we need to keep in mind. The inferior epigastric vessels are the superlateral border of this area.
So here they've just gone.
A useful trick is to pass a double thread below the vessels. So you just need one movement in this worrisome step. To secure the epigastric vessels, we use surgeon knots, but square knots are also effective. We perform a small modification of the original technique, doing a greater muscle mobilization for two reasons. The main one is because we consider that we could have better control of the epigastric vessels in case of damage. And the second, and not least, is the teaching of our residents. To have a clear view of the whole course of the vessels in the external border of the muscles, it is fundamental to liberate the whole lateral border and to maintain a good medial traction of the muscles.
So it's a nice dissection technique of using the right angle retractor to open up a little window there, isolating the vessels as a pedicle so that you can
As a useful trick, we leave a long tail of the square knot to have a good reference for the section of the muscle.
using a little mini ligature here for separation, coagulation separation of the tissue. We use those during salpingectomies, during C-sections, and postpartum tubals.
At this time, we open the parietal peritoneum, but you can delay this step after cutting the rectus muscle.
Most folks would be separating the muscle first, then opening peritoneum.
Both rectus abdominal muscles are cut by electrocautery, being sure that we are between the knots we have secured.
It's a little faster than I would cut the muscle, just because even with the vessels tied off, there can still be a fair bit of bleeding there. So a little bit slower application of the cautery. See how protecting deep tissue with the finger there behind the muscle. You can see here on the patient's right that they've got a very, very wide exposure there, having cut the muscle completely. All right, so you can see then the ligated vessels here laterally, and then the cut surface of the rectus muscle. A real big area of visualization there. So I like that video from the perspective of identifying the vessels and ligating them, the way that you cut through the muscle. I do not like the amount of dissection they did with the fascia off of the rectus muscle. Perhaps if somebody had previous surgery, had a lot of scar tissue, you would need to create a little bit of a bigger space. But you know, if we come back and look at where was it, kind of even the beginning of it, they had a very nice separation of the fascia without needing to do any dissection. All right. So things we talked about with the Maillard. A muscle cutting, that should be cutting, not splitting. Muscle cutting incision, you really do need to leave the fascia intact and connected to the rectus muscle. It does give wider lateral exposure, maybe a bit more inferior and superior as well, but you really cannot do this after having done a fan and steel. With the Czerny, that's leaving the muscles intact, removing the rectus from its insertion point on the pubic symphysis. You have to reattach the tendon onto the symphysis, and you can perform a Czerny after having done a fan and steel. So the main difference is there. And just to highlight that again, if we look at the gray, this is my very poor MS Paint skills. So gray is fascia, red is rectus muscle. When we first go through, if the fascia is still connected to the rectus, that's kind of our native state, so to speak. If we do a fan and steel, then we've created a separation here, this white area. We've dissected the fascia off of the rectus, but then we just open the rectus, so we spread rectus to get the opening into peritoneum, which here is yellow. When we've done that, then we really just suture fascia back together, like I said. If you've separated rectus off of fascia and then come and do your fascial closure, your running closure here on the fascia, that's going to leave this muscle having retracted under its just natural resting tone. So you close fascia here, but you're not going to get healing of the muscle. So that's, again, one last highlight. That's why you can't do a fan and steel and then cut the muscle in a Maillard sort of technique. All right, so abdominal wall closure. Wounds have less than 5% of normal tissue strength in the first week. And so the way that we close the tissue is very important. The layers that we close, kind of, again, coming back up, so to speak, during a C-section, we close the uterus. Most folks don't close peritoneum. Some do, not many. Close the fascia, the subcutaneous space, kind of depending on depth, we'll talk about that, and then closing the skin. For the uterus, we usually use a 1 or a 0 vicryl or monocryl. Every now and then you'll see someone who has a little bit of an old school approach that'll use chromic on it, but that's pretty rare. For the peritoneum, if somebody's going to close that, usually monocryl, but occasionally you'll see vicryl and very rarely you'll see chromic. For the fascia, PDS or vicryl, a bigger suture, so a 1, 0 vicryl is acceptable. For the subcutaneous space, usually a 2 or 3 monocryl. Again, occasionally folks will use vicryl, very, very rarely chromic. For skin edges, there are some folks that will use staples. You're not going to see that a lot. With vertical skin incisions, you'll see it more, but with fan and steels, usually not. Most people use a 4-0, sometimes a 3-0 monocryl or a vicryl. I typically use the traditional curved needle. We also do have the Keith needle, which is a straight kind of a sewing needle type of look. So for the uterus, we close that in a single or double layer. For the most part, single layer is what the literature supports currently. Double layer closures have pretty much gone by the wayside. We use a delayed absorbable suture, like again, vicryl and monocryl. We're closing off the full thickness of the myometrium for healing and for hemostasis. When it comes to including the endometrium, and we'll look at this in a diagram in a second, getting a bit of closure through the endometrium is fine. You do want to make sure that you get beyond the apex or the corner of the hysterotomy. So if this is our hysterotomy here, we don't want our first suture to be here and then start working our way over, because this area of cut myometrium that is not being compressed by a suture could be an area of bleeding. So what's very important is, one way or another, to get here beyond the apex. So if you just come out here with your first stitch, that's fine, and then do your, again, running interlocking is what we typically use. Or what you can do is, let's say that your first passive suture does go kind of here, there's a little bit of apex beyond it. You can use an instrument like an Alice to come out and grab that apex and pull it medially, so that when you end up tying the suture, you're tying behind that area. So even though the needle's not passing lateral to the apex, you are going to get good tissue compression out there. So looking here at uterine serosa, which has been divided, the myometrium, and then the endometrium or decidua here with the little bit of a darker pink, we typically close just one bite through another coming out, so doing that in one layer. Again, the idea of kind of how much endometrial decidual layer you get, some folks, when they come down through myometrium, will really try to kind of skimp out here and not get much endometrium, so that they're not leaving much suture material in the cavity. But I think there are enough studies that have shown that that's not detrimental, so you actually do want to get a good kind of full thickness closure like that. And then when we tie that off, and again, we do that as a running interlocking, but you get good closure there. You can do a second kind of imbricating layer. What that typically looks like is, if this is our primary closure here, so we do have full thickness, but then you can come just above and below that first suture, grab tissue, and the goal with that is, with this imbricating, to kind of pull another layer of tissue over that initial closure, so that in the end you've got, you know, kind of one layer and then two layers of closure like that, without the gap in between, obviously, but that you've got that initial closure and then you've got another layer over that, just to thicken up this area of scarring and healing. Specifically when we do classical C-sections, so we're really up into the active segment, the thicker myometrium, we tend to do those as 2 or 3 layer closures. 3 layer closures are the most common. However, occasionally the myometrium just doesn't have quite enough thickness to really be able to get 3 full layers, and so we'll do it in 2. But the general idea, what I typically do, is to think about the myometrium and the decidual layer, the endometrium, and with this first pass, which is again running interlocking, getting about 50%, maybe a little bit more of the total thickness. Second layer, making sure that you come down to just right immediately above the first layer, and then popping out just under the serosa. Again, running interlocking for that, closing off the rest of the myometrium. And then what I'm sure you've heard of or seen, the baseball stitch, so this kind of third layer, which is really just closing the serosa itself. All the myometrium will have been closed with this first and then second layer. But that's what we mean when we talk about a 3-layer closure of the uterus for a classical C-section. As far as closing peritoneum, it's controversial. Most folks don't do it. Good surgical technique is the first defense against adhesion formation, and so you don't need to close peritoneum to prevent adhesions of bowel up to the rectus or to the fascia. Good hemostasis, gentle, minimal tissue handling are important. Closing the peritoneum is just not an evidence-based step. It does not impact the quality of the healing or the strength of the healed incision and tissue. And again, it may even increase adhesions by leaving suture material that's in immediate proximity to the bowel and omentum. Fascia, this is the most important layer to close for tensile strength. You only ever 70 to 80% of the natural strength is regained, even with a wonderful closure. However, we only need 50 to 20% of natural strength for day-to-day activities. So getting good closure, getting back to that 80% of natural is acceptable. Again, we use a delayed absorbable suture. Most commonly, I use a PDS. Folks also use a Vicryl. Monocryl really doesn't last long enough, and chromic the same is way too quick and just not appropriate. A running suture applies even tension along the edge of fascia, and you get better tissue perfusion. We don't do an interlocking. The fascia is a fairly avascular layer, so you don't have a lot of bleeding from it. We don't need to have the interlocking aspect, but just the continuous running. The 1-by-1 rule, most of the time, if we've got our cut fascial edges here, folks will say go back 1 centimeter from the cut edge and then travel down 1 centimeter from your next bite. So you pop through here and come out, and then travel down, come out there. There are some studies that suggest that you get less hernia formation, better tissue healing in smaller bites, anywhere from 5 to 8 millimeters away from the edge, and then traveling down only 5 to 8 millimeters. A couple of the studies were done in Europe, and so they're looking at patients that had lower BMIs than what we may see on average. So it's been slow to be adopted here. I tend to take a little bit closer bites. The subcutaneous tissue, so that campers, campson, scarpas, which makes up our sub-Q, and then underneath the fascia, which we've just closed, and above that, skin. It's really recommended to close the subcutaneous layer if it's more than 2 to 3 centimeters thick. I usually close it regardless of thickness, just to get a closure of that dead space and some bringing together of the skin edges. It can reduce seroma, hematoma formation, infection. You do want to make sure that that tissue is hemostatic before you close that layer. If it's a very deep subcutaneous space, occasionally I'll do that in 2 layers. And if it's over 3 centimeters, you can put in a JP type of drain, but that would need to go to suction, not a passive drain like a Penrose or something like that. So, skin, how do you close skin? Lots of options. Sutures, staples, adhesives. You'll see a little bit of everything, but most folks here use sutures, a couple staples, more so with verticals, although it's very, very acceptable and have a nice result using sutures, a subcutaneous type of closure, even with a big vertical midline incision. The subcuticular type of closure decreases post-op discomfort. It's less expensive than the staplers, obviously, just having a suture or two. There's possible reduction in scarring and some better cosmesis from it. You can use barb sutures to not even have to tie knots in it. And as I said, you can use it on vertical skin incisions for sure. Staples are faster, but they possibly have more discomfort and not as good of a cosmetic result. It is easier for drainage because you do have little gaps between the staples, and so you can get a bit better drainage there. There are also some dissolvable staples that they use. I've seen this in use out at the Ephrata Hospital a fair bit. As far as adhesives, they may save time. Overall infection rates are similar. Cosmesis, I think, is similar to subcuticular suturing. There's a slight increase in the risk of wound separation with using the skin glue. As far as dressings, the quality of a dressing, the type of dressing can affect wound healing. We tend to, at the hospital, use a silver line, which is a silver impregnated dressing. But you'll see a lot of variety there. We do have pico dressings, which are occlusive dressings that have a little suction tube that comes off and a little battery pack. Those are negative pressure dressings, so they, by creating that suction, will pull out any fluid. It's supposed to reduce post-op edema, gets better circulation through the healing tissue, increases the granulation rate, and so it can speed healing. And it is occlusive, so theoretically it will reduce risk of infection. Silver impregnated is what we use most commonly now, and then some, and I don't know if I've seen it here at York Hospital, but there is a Tegaderm, the polymer film, that's water permeable, and so that will create an occlusive dressing as well, which theoretically will decrease the risk of infection. So that's it for talking about incisions. We'll have a chance to talk about this more in person, and then obviously within the first couple of times during the operating room, you'll start to see all the different approaches that people take to this. So thank you for your attention.